as you all know, that International Forum for Promoting Homeopathy comprises of homeopathic doctors, lovers, and students. And we are conducting regular sessions from 7 to 10 p.m. in 3 different languages. Particularly the one just finished is the Hindi session from 7 to 8, and 8 to 9 we have international session in English, and from 9 to 10 we have a local language session in Malayalam. So let us introduce our guest of the day. Is none other than Dr. SAURAV Arora, MD. He is a gold medalist and is one of the faculty at the London College of Homeopathy in the United Kingdom and a member of Registration Society of Homeopathy United Kingdom, and is a guest faculty of Dr. B. Asur Homeopathic Medical College Hospital and Research and Baxton Homeopathic Medical College, and is a founder initiative to promote research in homeopathy and vivid homeopathy, and ex-senior research fellow at CCRH, INMS, and SMHC from 2008 to 2014. He's an ex-house physician 2007 to 8, and he is an author of 47 articles, including 20 peer-reviewed and 27 general articles. That means a wonderful personality by all means, and he has an experience of 17 years. And today, as you all know, that one of the biggest subject of the day is diabetes mellitus. There are different concepts going around the world about diabetes, and in particularly, we can say that 1 among 5 persons in Kerala is having diabetes. So Dr. SAURAV Arora has a different idea how to understand this diabetes mellitus in a different point of view, particularly from homeopathy point of view. As you know, it being of course there are miasms and everything there, and we are really anxiously waiting to see what a doctor has to say about this particular so-called incurable disease. As far as the allopathic people are concerned, they can manage the disease, but never they are able to cure a single case of diabetes. But the homeopathy has an exception. We can cure the patient if we get the patient from the very beginning itself. So let us invite our honorable guest, Dr. SAURAV Arora, to this forum. Welcome, sir.
Thank you so much, sir. Thank you so much for such a wonderful welcome and introduction. And I would like to excuse all of you because I have a bad throat today. So please bear with me. Without taking much of the time, let me first thank you to the organizers, to Dr. Sani, for inviting me and sharing my views. As I always say, it's my pet dialogue that my presentations are not a presentation as such. I would like to convert such presentations into dialogues, to discussions, because what takeaway message we get. Okay, we saw something on screen, we clapped. Okay, what message we have got, what message we have taken home, or to replicate that is important. Even if we take one single message, one single thing about diabetes or whatever topic we are discussing, that the discussion is fruitful. So without taking much of time, let me share my screen and then we can discuss in between what exactly I want to say about diabetes. I hope my screen is visible to all and I'm well audible.
Yes, everything fine, sir. You can go ahead.
Yeah, thank you, sir. Thank you so much. So today we are going to understand the key points behind diabetes mellitus. So honestly, I have not concentrated much on the therapeutics part. Why? For two reasons. The therapeutic depends on a person's judgment. It's an art. To replicate that art, we need much. I think we need much, much time to replicate, to learn that art. What exactly SAURAV is doing, what exactly one XYZ person is doing. So let us try to understand, being a homeopath, that what we think about diabetes. I'm not going to go into much details about the physiology or pathophysiology, but yes, it's a metabolic disease, it's a metabolic syndrome that require right medical diagnosis, the treatment and lifestyle changes. Earlier, there were diseases, now there are syndromes, and the day is not far when we will convert every disease into syndrome. Why? Because they are affecting more than one system, right? Okay. So we started our medical journey maybe 20 years back. We used to, it's a disease. Now the medical book says it's a syndrome. Why? Because it affects holistically. So that holistic part is the homeopathy which we have been taught, reading, and trying to understand for the past 200 years. That if we talk of a holistic nature of a person, there is a holistic nature of a disease also. It is not that the pancreas is affecting, it's affected, but it is affecting each and everything, even the psyche of the patient. So we'll talk something about the psyche in between. So going by the number, there are huge numbers, huge numbers, which we don't want to discuss. The plus point, yes, we are getting diabetes very frequently in our practice. Every third, fourth patient comes and says, "Sir, my report is altered. I have diabetes mellitus. I have sugar." The common term, the sugar. I have sugar. Can it be cured? So, can it be cured? We'll learn about. So, in the later part of the presentation, that yes, it is attributed to various factors. It is prevalent in every part of the world. There is no place that is spared because it's spreading holistically. It is now one of the most common endocrine disorders, which is affecting each and every strata. We used to think that it is a disease of the people who are obese, who are they have their sedentary lifestyle. But nowadays we are seeing each and every, even the kids are affecting by the diabetes mellitus. Now the point, persistent hyperglycemia. Now this point is, we are obsessed with this point. The patient comes, "Sir, I have persistent hyperglycemia. My sugar levels are high. What to do?" Okay, we give a treatment. And the aim of the treatment is to reduce that hyperglycemia. We are not thinking beyond that hyperglycemia. Okay, fine, your sugar has gone down. Are you okay? So this persistent hyperglycemia, I think we are running around this only, that decreasing sugar level is the treatment of the diabetes, which is not. The patient comes with a point of view of reducing the sugar. We treat with the point of view of reducing sugar, but we are not understanding the story behind. So the story behind that, yes, it is because of the inadequate secretion or inadequate response. Now, if pancreas has stopped making insulin, from myosome point of view, we know that it is stiflating myosome. But when there is inadequate secretion, when there is inadequate response, can't it be psychotic? So then only the type of diabetes you are dealing with and the myosome associated. Now this is important when we talk of intercurrents. We'll talk about such few intercurrents in the end. That yes, we know that type 1 diabetes has come, type 2 diabetes has come. The insulin levels, what are the insulin levels? And I'm sure majority of us, we don't bother to get the insulin level of the patient done. It's a very common test nowadays. You can advise serum insulin fasting and serum insulin postprandial. Along with the sugar, we can actually see the levels of the insulin in the body. So holistic presentation, then the local presentation is the key point. Moving further, we know quickly that we have type 1 diabetes mellitus and type 2. And type 2 is common and type 1 is not that common. But nowadays, I think you will agree with me that smaller kids are coming with type 1 diabetes mellitus. Kids of 8 years, 6 year, 10-year-old, they're diagnosed with type 1 diabetes, juvenile diabetes. And what is the outcome? Nothing. We're only struggling around, decreasing the sugar levels, and that's all. Nothing else we can do. Yes, we get type 2 diabetes more than type 1, and we are successful in reducing the sugar level. But what next? These factors, yes. Increasing age, we can't do anything about increasing age. It will increase. Altered food habit, sedentary lifestyle, obesity, and the other certain medications. So whenever a patient comes to us, do search these medications and their side effects and their contradictions. Why? because in majority of the places where we practice, the patient nowadays is very alert. He has experimented things on YouTube, by seeing Google, by seeing Instagram reels. You know, fresh diabetic case, you will rarely get fresh diabetic case. Those who say that, sir, we have this problem and we want to consult you firsthand. So majority of the time, what is happening, they have been experimenting themselves with the juices, with the combinations, with this, with that, and now they're presenting to you as a challenge to you. And to deal that challenge, you need to, you know, see the inside story. What have you taken? Till what to what extent have you taken? Okay, fine. You took this medicine. This medicine says that the contraindication is diabetes mellitus. So always understand the psyche of the patient, what he has experimented with. Now, this comes under case taking. We all are home pads. We take exhaustive case taking. When we come to diet and regimen part, we know what we are asking from the patient. Okay, what is your diet? What is your regimen? What have you experimented? How many medicine have you taken before coming to me? And they will say, sir, we have tried this, we have tried that, we have tried that, and we are not cured. Why? Because it is acting partially. Now we want to get cured. Now this is the most common thing the patient asks to you. So can it be cured? Straight away, the patient is not telling you the story. The patient is not telling you the details. The patient on the first instant asking you, so can it be cured? And we are in dilemma. And we claim, oh yes, it can be cured. But how? Let's see what we should tell the patient. Now there are two type of things we encounter in our practice. One is accidental diagnosis versus routine diagnosis. Nowadays, the ratio is very broad ratio we are encountering with accidental finding. The patient, get their investigation done from a lab, from a camp, or doctor ask, or their routine checkup, health checkup before joining an office. The sugar came out to be little high, and they were started with the treatment. Now, this is the problem. On single report, I've seen the conventional medicine practitioner, they start the straight away the oral hypoglycemic without getting the test repeated. Now, let me tell you, I've started repeating the test. I don't, always have a suspicion on the first report. So whenever a patient comes to me, I ask them, okay, fine, take 2-3 days, take 1 week, take treatment. I'll start your treatment. But I need that cross-checked report with me. And with the diabetes and especially thyroid, you will see the majority of the patient, their ratios would be altered even the next day. I came across a patient who reported, sir, I have a 30 TSH. And I was, not very pro to believe that report. So I asked, can you get it repeated the next very day from another lab? Because, there are certain kits in thyroid you use. So I told them that this is the reputed lab, you can get it done. The TSH was 2 point something. No, from 30, that was an error. I know that was an error. And the TSH came to be 2. So even in diabetes, the accidental diagnosis and treatment, they are in boom. For they're being oral glycemic for 3 months, 6 months, 12 months. Now what is the problem? The problem is artificial disease. If the patient is taking a treatment without having any symptom, without having any diagnosis, without having any need, and unnecessarily he's taking any treatment, can't be termed that as artificial chronic disease, which we have been taught for years together. And majority of the time we are suffering because of that misinformation. We are struggling with to get that artificial disease online. So we ask the patient, okay, fine, stop it, taper it off, this and that. So understanding the routine versus accidental diagnosis straight away tells you the psyche of the patient. Patient is so apprehensive that someone said, you have sugar, your levels are 110, maybe 114 blood sugar fasting. The very next morning, the very next day, the patient stopped eating everything. Patient started exercising 2 hours a day. Patient stopped every junk food. Patient made his life miserable. I won't say comfortable, miserable. Now, this is the anxiety towards disease. On the other hand, you will come across patient. Again, the blood sugar fasting is 114, 120 or increased a bit. The patient is okay. I will eat everything because I know the diabetes can be taken care of. I will do this and that. I don't want. So, at two scenarios, you can find the appropriate rubric in such patients. At that very time only, their anxiety towards disease, their anxiety towards health. Now, there's a difference. If the patient keeps on thinking about disease, 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 it is anxiety, it is apprehension, it is fear. So always cross-check with these rubrics. But the patient has certain disease and is pointed towards health. I'm exercising, I am dieting, I am doing this, I am doing that. That has, and affinity towards health, anxiety towards health. So we'll learn this gradually. I have certain things to discuss at the end. So the classical symptom, sorry, we don't get any classical symptom. Even in majority of the patient, even I think the majority of us would agree, there are no classical symptom nowadays. Why? Because of the masking. The patient has tried each and everything, because they are alert in certain cases that at initial symptom, consult a doctor. And because of the individualization, you will not find these bookish symptoms in each and every patient. Polydipsia, polyphagia, polyuria. I mean, rarely we see one or two patients, okay, it has polyphagia or polydipsia, or maybe polyuria, but fatigue, weight loss, they rarely get in each and every patient. So what exactly we are dealing with? We are dealing with the variable symptoms presentation. So that suspicion about the patient, referring or being referred for diabetes, being referred for investigation, we should be very thorough that each and everything can point towards diabetes or thyroid nowadays. There are no symptoms. They're not classical symptoms. And yes, we have discussed this thing many a time. Patients are diagnosed with the routine investigations on the basis of non-specific or trivial symptom, the routine diagnosis, which is nuisance nowadays. Once they get one report, they will start experimenting each and everything. Okay, let's move further. There are certain symptoms, type 1, type 2, almost common symptoms. So I'm not going to go into detail of these symptoms in this presentation, because this is an exhaustive presentation from different point of view. One important part before coming to the homeopathic understanding, the complication. If the patient is so alert, if the patient is so anxious, and we see that majority of the patient, they go into complication. Now these complications are, they don't have any U-turn. Once these complications have set in, let me tell you, we all know we can't do anything. The patient has developed retinopathy or nephropathy. I'm sure you must have tried each and every remedy with that in that patient. I tried many a times. The patient says, I have burning and numbness in my toes. If it is initial, yes, you can give some symptomatic relief. It is stable, it is. But if there few months have been passed on, that complication has set in. You try phosphorus, you try arsenic album, you try cuprum metallicum, you try syzygium, you try cephalinum, multiple remedies, single dose, multiple dose, tinctures. It is not going to do any good for the patient. He will have temporary relief, and after again few weeks, few months, he will again come, sir, I again develop that burning. Why? Because my sugar is not controlled. The complications, they don't have any U-turn. You can only suppress them or deal them partially. Palliation can be there, but there is no cure, because that has advanced to that state. So prevent that complication. Ask the patient to get few investigations once in a year as routine. Eye testing, it is very common nowadays. You tell them, okay, fine, every 6 months or every year, get your eyes checked up. It is not that hard. Investigation, yes, every year one everyone should be getting the few basic investigation done. And especially the diabetic, the investigations are a problem. So acute complications, we know the diabetic ketoacidosis, the hypoglycemia, even the amputations. And the major complications, they are retinopathy, neuropathy, nephropathy, and cardiovascular accidents. When the cardiovascular accident has set in, I'm sure the patient is in problem. The doctor is in problem. What to comment? What to commit to the patient? I'll share one of the example experience with you. A patient comes, and it is a very quite common example. A patient comes, sir, I have got high blood sugar levels. I stopped eating. Why I stopped eating, sir? I searched on Google, I searched on this, I searched on that. That dieting should be there. So I am on diet. I have stopped eating almost everything. So what do you eat? No, sir, I eat only one chapati in the morning and one chapati at the night. So what do you do? Sir, I am into this business. I do go to office. I do this and that. After few months, that patient will be in problem. Why? Because the body's consistent need of calories should be met with. If, suppose a patient needs 1200 kilocalories a day, and that patient has reduced those kilocalories to 300, 400 on its own. Rest of the calories the body will use from glycolysis, from breaking down of the fat, and breaking down of muscles. And when the body breaks muscles, let me tell you, the first complication the patient would go increase uric acid. And the patient will say, sir, I am on strict diet, but my report says my uric acid is increased. Means I have one more disease, that uric acid diathesis. It is not because of the disease, it is because of your dieting. Dieting does not mean stop eating. Such patient, they undergo diabetic ketoacidosis more frequently than the others. So always tell the patient, okay, don't stop eating. You need to regulate your eating, not stop eating. So this is one of the acute complication, everybody will ask, get uric acid zyada aa gaya. How come it, came? Okay, fine, you're into problem. Why? Because you are eating in a wrong manner. Moving further, I found this online. It's a good this thing, that tight control of blood sugar and the poor control of blood sugar. All these complications, they actually happen in diabetic cases. And once they happen, let me tell you, there is no U-turn, there is no way out. The only thing is they have to adjust in life with these complications. Diagnosis and investigation, let's have a bit of understanding about the diagnosis and investigation. We know that there are blood sugar fasting, the postprandial, the random sugar, the glycated HP, the serum insulin levels. Now let us understand the psyche of patient. Sir, I can't go to lab in the morning, so I got my random blood sugar level done and they're fine. Okay, this is the most common statement patient give to us, because they don't want to come out of their comfort zone. For them, getting a sugar tested done at any time of the day is understanding the diabetes, that yes, my random sugar is all fine. Why should I go for the fasting? Why should I go for the PP? And even if one patient comes to you, there are certain things. For example, divide his follow-up over 4 days. Ask them to get one fasting PP done, one pre-lunch, post-lunch, pre-dinner, post-dinner, and one 4 a.m. in the morning. Why? Because that 4 a.m. in the morning, the insulin is secreted in the body because of the diurnal variation. Now, in such cases where the patient is obsessed with only blood sugar random, okay, I pricked my finger during the daytime, any time of the day, it is 180, it is 200, I'm all fine. There is no need of the treatment. What if that patient is suffering with the impaired fasting glucose, which is pre-diabetes, which is very common? Why? Because of inadequate secretion, because of the poor insulin and good insulin resistance, which is a psychotic trait of the patient, that impaired fasting glucose is the presentation. No, let us take an example. If there is a traffic jam, every car wants to go ahead, and there is a jam, until unless some traffic guy come, or any guy come who will stop other cars and let the traffic diverted to good routes, there will always be a jam. It can be there for 2 hours also, it can be there for 4 hours also. And it can be cleared within 10 minutes. You must have observed. This is insulin's work. So whenever insulin comes, if it is inadequate, it will allow the sugar to have that jam in that particular area for longer hours. So always don't go by the patient's comfort level. Ask them to get one fasting PP done. Nowadays, the handheld machines, they are very common. The prick machines, they're very common. Ask them to get them done. At least you have one range to follow. The other problem is the HbA1c. Majority of the patient, they come to us, sir, my HbA1c is 6 or 7. I don't want any treatment. I stopped the treatment because my HbA1c came to 7. Okay. So my HbA1c is 7.4. Please start treating me. Where is your fasting and PP levels? So there is no need. I have read on the Google that it is the 3 months average, and my HbA1c is 7. I want to get the treatment. Now this is misnomer. It's an average of past 3 months. What if you have increased blood sugar levels today? What if I want to see the variations? Because if I am to see the variations, I know that you are a non-compliant patient. Why? Because I know your sugar levels were very fluctuating over the past 3 months. You did not comply with the management. Now, such patients are reluctant. Such patient rubrics cannot be careful patient. They're careless, heedless patients. There and then only the compliance says you that can this patient be carcinosin? Can this patient be arsenic album? Yes. Many of the patients, they come with very fine handwritten papers with you. Sir, I got my investigation at home, whatever, and I beautifully wrote each and every with time and all because I'm a very meticulous patient. That there, then and there only you need the remedy, the constitutional remedy. We'll come to the basic remedies further. So this compliance, basically, you can convert that compliance into understanding the patient's psyche, which is important to understand the diabetes mellitus. Then serum insulin level, many of us, we get it done, but yes, they should be done just to see whether it is only the inadequate secretion or the insulin levels. What are the insulin levels, actual insulin levels in the body? Other tests, liver function test, lipid profile, kidney function test, eye examination, they should be done. And in addition, the specific test should be done. These are not very, those tests, earlier they used to be very costly, very out of the pocket, out of range, out of reach test. Nowadays, every single lab does it. So what is the problem? Get it done. Moving further, now, actually coming to the goals. NIP, the normalcy of blood sugar levels. Now, we started with this in the beginning, that this normalcy of the blood sugar level is the only the single most point of concern and talks of the doctor and patient. Okay, your sugar levels are high. I'm going to get your sugar levels normal or lower them. This normalcy. Let's take a step ahead. The improvement in overall health. How are you feeling? Is your weakness gone? The patient says, sir, my sugar levels are all fine, but my weakness is not gone. I still feel weak. I still feel, as if some heavy weight is on my chest, on my head. I still feel anxious. I still feel feared. I still feel numbness in my toes. The initial phase. So improvement in overall health should be the next equal goal in our diabetic patients. Prevention of complication. The patient will thank you after 10 years that, sir, you told us this thing right and it happened. And the practitioners like us who are into practice since few years now, we can follow patients and families. Now they come and say, sir, you told me right, 10 years back, 15 years back, now I'm all fine. They're not taking treatment from me. They're not taking treatment from anywhere even. But whatever we guided, now this guidance is basically our understanding of philosophy, the diet and regimen. We all have read it, we all have studied it. Now we need to follow, and following this is not a very big deal, right? So this nip is important. Now, maybe I'll share this table with you. Now, this is the obsession. So my blood sugar is 109. Should I need treatment? If I see the table, it should be below 110. You're all fine. It is normal. But what if your PP is high? Now, these ranges are basically a notorious ranges followed over the years. What happens? Earlier, a few years back, it used to be 100. Now it is 110. It means over those years, the 10% of the population who was in the range of 100 to 109, they become diabetic overnight. What if I change the range tomorrow to 120? Millions of people straight away will come to diabetic range overnight. Why? Because my sugar levels are 111, and as per the table, I'm diabetic. I have impaired fasting glucose. Always take a range. That the numeric obsession should be avoided. Now, that numeric obsession is basically part of the psyche of the patient. Like arsenic patients, they're very obsessed. How much number, sir? My sugar was 84, now it is 89. How can it be increased? My sugar level were 109, now they are 113. What happened? No, 5% intra and inter assay variations can be there. In every report, in every, it's a worldwide phenomena that we take 5% intra and inter assay variation. For example, intra means if you take the same sample, recheck that sample at different point in time, you may have that reading which has 3 to 5% error. And if even if you take the same person sample over few days time, maybe today and tomorrow, there may be a range variation. So that 5% range variation is allowed. We should be very vigilant to deal with that. Even if you're 105 or 109, it doesn't make any big difference. Your range is still on the higher side. For diabetic, the good control says, which I follow, if their PP is between 140 to 116, even 180, I would say there is no problem. For fasting, I take the range as 120. Even if they have 120, less than 120, I know that their controls are good control. Whatever goes beyond 200, it is not a good control. But if I say the range that it should be 140, 150, 160, it is 1 till 180, there is a good control. Now, again, we were talking about the HbA1c, the obsession with the HbA1c, that, sir, my HbA1c has gone down. I will eat in each and everything. No, that was the retrospective average. That was the balance in your bank in the past 3 months. One day I put 1 lakh. One day I withdraw 90,000. One day my bank account has 0. The other day I put 2 lakh. So whatever the bank does, it takes your average of the 30 days of your minimum average balance. So this HbA1c is minimum average balance. Over the past 3 months, it is not the actual balance you have right now in your pocket or in your bank. So be very alert. I don't go with these HbA1c very emotionally. Okay, find your HbA1c. Yes, I am concerned that over the time your HbA1c should come with. I take 6.2 or 6.3 as cutoff. It is good. It is good. Whatever it is more than 6.5, it is bad. But I'm not very obsessed. I know that your fasting and PP levels are consistently going down. Your HbA1c will eventually go down. Moving further, every 1% drop in HbA1c decreases the risk. Now, this is homeopathy. If your patient is taking any treatment and you have started a treatment and they started reducing their HbA1c from 8 to 7 to 6, you're actually reducing the number of complications. You can see 37% decrease in microvascular diseases. And these are not apparent. They will be apparent when the patient has gone into that syphilitic state where there's no U-turn. Now, One important aspect which I think that is we need to understand is the hypoglycemia. It has more complications than the increased sugar itself. It can be life threatening. You must have seen people fainting in the banks, on the railway stations, or here and there in conferences. Always suspect for the hypoglycemia first. The hypoglycemia and hypotension both, even if they've not taken water, yes, it is hypotension, but hypoglycemia is equally can be, just a second, it should be thoroughly investigated. So prevention is better than cure. Now how? Rule of 15, sorry. Whenever the blood sugar levels fall beyond 70 milligram per deciliter, now we have all handheld devices to check the sugar levels. Whenever it is below 70 or 70, give 15 gram of carbohydrate to the patient straight away and check the levels after every 15 minutes. Now, this is rule of 15. Now, these, you can see the list. The following item contains approximately 15 gram of carbohydrates, half cup of orange juice. Well, it's not really available, but yes, it is there. 1 tablespoon of honey or syrup. When we are at clinic, syrup, even if you have any syrup, that is a sugar-based syrup. You can give. There is no need to search for the orange juice or any honey. Even if you are at home, honey is available. If it is not, any syrup will do. 1 tablespoon of sugar or 5 small sugar cubes. Now, I always ask or suggest my patient to carry some mishri, some sugar, or if it is not available, 2 toffees in their pocket every time. Plain candy, plain toffees, because they're rich in sugar. So whenever you feel hypoglycemic, whenever you feel giddy or low, there is no harm taking that mishri or that tablet or that candy or that toffee, because it's a quick source of energy and it can prevent complications. Moving further, management. Now, this management should be appended with our knowledge of homeopathy. Education. Now, I'm not talking the education the patient has got from Google or Instagram or YouTube. I'm not against these channels, but the problem is that we are selective for our, we will selectively pick information. We don't want to read each and everything, tick, 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 5 points in diabetes, and my diabetes is cured. No, no, no. That diabetes is not the disease which, 5 points can teach me. So the education is basically the education on the part of physician and explaining the same to the patient itself, because it's a long-term process. If we want our patient to thank us after 10 years down the line, 20 years down the line, educate them right. And it will create a difference. Every diabetic patient comes to me, I take the class of 10-15 minutes or 20 minutes, and I explain them each and everything, even if they're not going to come to me again. It's okay, no problem. But I did my duty. I explained them that your diabetes is this. You need to overcome this. And this is individualized approach. There is no article on diabetes which is applicable to each and every patient. So whatever you have got, whatever case you have taken, your education part is dependent on that case. The patient's callous attitude. You need to approach them accordingly. The anxious personality, the fearful personality, they get feared easily. If I talk of complication, they will be in problem. They will not sleep all night. So what my part of education would be to calm down, to explain in their own simple language that yes, you can control it, you can treat it. Because half of the treatment is in your pocket. I'm only giving medicine, I'm only giving certain medicine with certain mindset, for certain months or weeks or years, but you have to follow lifelong this thing on your own. So the patient has equal right to know about the disease, the knowledge of disease, basically, understanding. Now, this understanding is important because only lowering sugar, I think it is not our cup of tea. It can be, we can get it done through any means. The problem is that understanding its situation, its prognosis, depending upon the patient's mindset, patient's environment in which the patient is living or struggling with, his mental state, his compliance. For example, if the patient says that I live in a hostel or I have food from a mess, can I ask that patient to have dietary regulations and changes? No, I get few students from hostel nearby, and every time they come with a throat infection, I say, okay, avoid spicy food, sir. Our mess food is very spicy, and we can't do anything because it comes equally for everyone. They can't have that, less spicy food because they're living in a hostel. It is they need to have that mess food every time, right? Not every diabetic land up in complication, and this should be the other way around also. Let us not let every diabetic land up into complication. Participation in the health activities. Now, what are these health activities? For example, dietary restrictions or exercises. Now, let me tell you one small story.
Yes, sir, you are muted.
Yes, sir. Now, let me tell you a story or real life instance. When the patient, is diagnosed with the diabetes, he will take a gym membership. Sir, I went to that gym, I went to that health center, and I took 1 year membership. Sir, I took this treadmill at my home. After 2 months, that membership, the whole year membership will go into veil. After 3 months, he will be, putting his old clothes to dry upon on that treadmill, nothing else. We take unrealistic targets and we let patients to take unrealistic targets. Now, we need to have a non-measurable, realistic target or participation. Okay, fine. Can you exercise 25 minutes for 5 days in a week? Yes, sir. Take 2 days off. Take Saturday, Sunday off. Why? Because if you are exercising 2 hours a day, after 1 month, 2 month, 3 month down the line, you will be exhausted. And you will, people will think, okay, अच्छा कल करेंगे, आज करेंगे. One of my friends, used to say, Saurav, the first of a month and the Monday never comes. Majority of the patients are, next Monday we'll start exercising. From first, we'll start exercising. That first of the month and that Monday never comes. So take that realistic targets, the health participation activity. For example, give them simple exercises. For example, can you jump at home? Can you do PT at home? For example, we used to do PT when we used to go to school. The first thing, do PT, do prayers, and then, because a healthy mind only comes when there is a healthy body. If we are feeling lethargic physically, our brain will not work. We need to have that push, that exercise, that warm up exercise. Cycling, don't do a 3, 4, 5 kilometer cycling. Only 15-20 minute cycling is sufficient for you. Why? Because you may go into hypoglycemia. I've seen patients exercising rigorously for no use at all. So that participation in the health activity should be realistic and according to patient's need. Now, this is individualization. Moving further, we have discussed about saving kidneys, eyes, and other important organs. Change of diet. Dieting does not mean stop eating. Always let the patient understand that yes, you need to eat, but you need to eat in a manner. Frequent meals. Why? Just to avoid hypoglycemia. Obviously, avoid the sugars, avoid this and that. But there's a catch point. For example, if I'm going to, going to go out 1 kilometer, 1.5 kilometer away from home, I tend to take rickshaw. Why? Because it is easy, it is convenient. What if I'm being told, Ki, Saurav, just walk, it is 2 kilometer, 20 minute, 2 kilometer, we can walk in 20, 25 minutes at a decent pace. I will not walk. Who will walk 2 kilometers? Oh, let's take e-rickshaw, let's take a cab, let's do this, let's take a lift. Body does that. To break complex sugar, body needs that energy to break even. For example, the banana, the diabetic can eat banana because the banana's sugar is complex sugar. Yes, you can ask them to take infrequent, not daily, not 2 or 3 times a day, but once or twice a week they can eat banana. But the grape sugar, it is simple sugar, so body will absorb it easily. It's a shortcut. So simple sugar should be avoided. The complex sugar can be taken. Now, exercising, we have discussed this. We're just running on time. Exercise do nothing but majorly it gives a psychological boost to the patient. Yes, we know the benefits of exercise. It improves circulation. It improves this. It is good for weight management. But above all, it gives confidence to the patient. The patient will say, "Sir, the moment I started exercising, I am feeling better." That I feeling is what? That is what we have been taught. The subjective feeling. From homeopathic point of view, I feel better. I am going good. Sir, the moment I started exercising, my problem started going away. So this psychological boost is important. So it should be a realistic, targeted exercise. Now, there's a catch point. Understanding point of view, there is a difference between exercise and exertion. The patient says, "Sir, I work 18 hours a day." Nowadays, I also work 18 hours a day, but I'm not exercising. I'm exerting myself, right? So basically, exercise is toning up of your body in a particular manner in that instant in time with a bent of mind, which is a positive bent of mind. If we are running, to a market, walking 10,000 steps, it is we are exerting ourselves. It is not exercise. But if we are in a garden, and we are running and having brisk walk, and we completed 3 or 4,000 steps, took a break, and then again went for a round of brisk walk, that is exercise. So always and always make the patient understand. Don't exert yourself. Do exercise, realistic exercise, according to patient's need. You can't ask a patient of arthritis at age of 80 or 70 to run. Why? Because he or she can't be running, won't be able to run. So even if the patient diabetes, the levels are 400 500, at such a huge level, the chances of going to hypoglycemia is more than the others. So don't ask them to exercise. Ask them to do some yoga, some meditation, and gradually, when the levels come down, when the body's metabolism is in sync with the body, he'll ask them to exercise more. So basically, it's a psychological boost. Now, coming to role of homeopathy quickly, yes, it can be used as add-on therapy. The patient first questions are, I'm taking a treatment, whether I can take homeopathy along with this or not. Yes, we can take homeopathy. We can give homeopathic to you. Why? Because we are acting on that immune system improvement. Now, this is for the we should explain this to the patient what we are doing actually. Are we lowering sugar only? No, we are lowering sugar, but along with that, we are improving your nervous system, your immunity, so that your tendency to go into such stages is lower down. Now, these three things we encounter in our practice. The patient who are into initial stages, which are detected early, the patient who are into developed stages, and patients who are into complications. Now, the initial stages is the constitution or the individualized treatment has a major role to play. Yes, we see some cures in some cases because the patient is detected very early and we know the patient's metabolism is compliant. In such cases, we give treatment from few weeks to few months. When it comes to developed stages, we have some specific medicines to control. Yes, because it has developed, the patient who takes this tincture, that combination, yes, we use that. Those specific medicines, they are to be given, they're given to control the blood sugar levels, and usually it is followed for few months to years. When it comes to complicated cases, the specific medicines, they have a good role to play. See, because the pathology can't be reversed. So you can convert your treatment into certain levels. For example, the patient is coming to you, you have certain constitutional or individualized or indicated remedies, then you have some specific remedies, and then you have some intercurrent or anti-miasmatic remedies. When it is initial stage, the constitutional has a good role to play, it is majorly there. You may or may not use specific. When these are developed stages, along with constitutional, specifics they pop in with intercurrents. And when it is complicated, you have specifics plus intercurrents. And in the background, yes, you can give to improve their immunity some constitution or the individualized. So this is how we are treating. But we need to document at certain levels that yes, the patient came to us in developed stage and we use these specific remedies or targeted remedies. Now, specific has a very philosophical and dilemmatic or diplomatic use in homeopathy. Specific means targeted. Maybe it can be tincture or the low potency, repeated forms. It is allowed because it is in sync with the patient. Add-on therapy, yes, we can give add-on therapy to the patient. The patient asks, "Sir, can I take treatment of yours with my homeopathic along with my allopathic treatment?" Yes, just give a gap. Yesterday also, I talk upon this, that this 30-minute gap which I have written, it is just indicative and it is not based on any experimentation. It is just to clarify things that the patient understands and we understand. Because if we keep things on loose and okay, take whatever whenever you want, the patient won't follow that. So this 30-minute is for understanding a biphasic understanding. And the key point is to treat holistically and a regular checkup of the blood sugar levels. These are some of the specifics along with the constitution which everybody use, but I think their usage, just convert their usage into three stages about the initial, develop, and complicated. Now we see that in complicated cases we use azinium also. Nowadays we are using 1x. Okay, Cephalendra, uranium nitricum, even insulinum 3x. It has a role to play. As a common myth, mother tinctures are not always superior to potencies. It is the right potency. This right potency is basically according to patient. Even the tincture is a potency. It's a base potency. It's a mother potency. And one should not take medicine for diabetes without supervision. Even homeopathy. I've seen patients taking tinctures for longer durations, for months together, years together. Sir, I'm taking this treatment for 5 years down the line. I took this tincture. Then why you came to me? Because you are not cured or managed or treated. Right? Now, takeaway message. I'm just winding, I think, on time. The treatment of diabetes is biphasic. Means the patient has equal responsibility than uh, in sync with us. We have the responsibility. The patient has also the same responsibility. There should be a compliance for the diet, lifestyle, and exercises. Regular monitoring, ask the patient to get it done. If you get it done, get it done. Okay, sir, I'll get it done today, tomorrow, after a month, after 2 months. You lose sync and the patient is lost. I'm sorry, the patient will never, these patients, they never come to us. Self experimentation and self medication should be discouraged at each and every level because it's an understanding of the disease, of the patient, of the individuality. So with this, let's stop diabetes. Thank you so much for your patient listening, and we are open. We have like 5 minutes for the open discussion. Thank you.
Yes, congratulations, Dr. Arora, for your excellent presentation in this forum. Particularly the diabetic management is very, very important, as you rightly pointed out, and there are certain misconceptions about diabetes, and the social media platform giving lot of producing making a lot of issues to the people public also because once they addicted, most of the people are addicted to the social media, and the social media is seem to be the big doctor for some of them. And as a result, what happened is whenever a patient, as you rightly pointed out, that if the patient is having a diabetic level just like one 111 111, then the patient may rush to the oh, I have diabetes and I have this problem and I have to take medicine, I have to consult a doctor. Or then what happened is nowadays people just going to the so-called the people from the other side, and naturally because of the intense pressure on the doctor may prescribe the allopathic medicine, and once the patient start taking medicine, they most probably most of the patients are not taking any exercise and diet control, and that will really do much damage than good. Anyway, the proper timing of diet is also one of the major point you might have missed because of the time scarcity of time, but that is also very important because people, I know there are people who used to take exercise by about 10 p.m. and then come back to home and then take a heavy supper. And definitely, what is the use of doing all these things? And both these things were waste for the body of the patient as well as the person itself, and that he may have cardiac arrest by about 3 p.m. or 3 a.m. or 4 a.m. What's your opinion on that, doctor?
So actually, we go by convenience nowadays. We are taking treatment, we can take anything. We are exercising, we can take food wherever we want, because body is our property. Our body will take care of our metabolism is so strong that you rightly said that after exercising at 10 p.m. at night, after gymming, okay, fine, because my body has used so much calories. Now this is mathematics they're following. My body has used this 150 200 kilocalories, so I should take 300 kilocalories, so as to maintain that. Body does not go by that. The people, many time people are missing with the concept of glucogenolysis and glycolysis, because it's a vast topic. We can discuss in 1 hour, and we can discuss in 10 hours. You will
Definitely.
find two pages book on diabetes treatment, and you'll find this much of thick book on diabetes. So
Yes,
we need to have that understanding.
exactly. We need one more presentation of the subject for discussion, because that's where
Yes.
I hope that you can do that later.
Yes, please, please. Maybe next time when we do, we can concentrate on therapeutics and understanding from that point of view. We discussed broadly the understanding today on from that point of view. Maybe that what exactly therapeutics is doing in such cases.
The other point you pointed out was also very right, because people used to do exercise for 1 hour, 2 hour like that, but then they stop all of a sudden, and that will end up in other big problems for that. Actually, only 15 to 20 minutes exercise is the best thing. What I do is I just allow the patient in the clinic itself. I start giving just 4 exercises. One is, as you pointed out, just jumping like one, just like doing jumping. Then for PT exercises, all these will end up within 10 to 15 minutes. That's enough for the patient so that he can do it every day. Otherwise, if 1 hour from a day or half an hour or walking 4 kilometers a day, it's a big problem for them. And the climate is also very important for them.
Yeah, yeah,
But
exactly.
hey, it's over to Dr. Hibbert for his.
Doctor, can you hear me?
Yes, sir.
Yes,
Very nice presentation. What you are reaching the core point of handling diabetes. I want to ask you, Doctor, which are the conditions you consider that the beginning as irreversible condition of diabetes?
Sir, I didn't get your last point. What are the conditions?
Irreversible condition of diabetic. In how can you find out the stages?
Stages.
Initial stages.
Initial stages. Sir, basically, first is symptom only, because, for example, if you talk about, I club this with the age and the risk factors. More the risk factors, more are the chances to go into complication. For example, just number. For example, simply I'll tell you, if a patient has dyslipidemia, I'll give 1 mark. If the patient has obesity, I'll give another mark. If the patient has sedentary lifestyle, I'll give the another mark. More the marks, the more chances into go into problem which are irreversible. If the patient is lean thin, diabetic, his diabetic control can be a good control. And I go by the basic investigation in the initial years. For example, your lipid profile, your maybe ECG, or maybe echo or X-ray chest, or maybe the kidney function test. If your kidney function is not getting that microalbuminuria, you're good to go. That is the first thing we miss usually. The ALP, alkaline phosphatase, it is increased in the liver also. It is increased because of the kidney pathologies also. If the ALP is all fine, unlikely the patient is going into problem. So this microalbuminuria, this ALP, these are such small indices which usually we miss, or maybe GGT or SGOT, SGPT. So I go by the basic investigation. I go by their levels, their compliance. But yes, I do not, let them or miss the numbness or tingling in the toes or their vision problems.
Thank you, sir.
Yeah, thank you.
And now it is up to Dr. Rambarisha, sir, to say. Yes.
Hello, sir. Very, very thanks. Nice presentation for
Thank you, sir.
treat diabetes mellitus. Very important. Exercise is a very important role of diabetes. There are 4 exercises: walking 3 to 5 kilometer essential, and jumping, and जो है एक तरह से jumping. So there are many kinds of medicine, not curative way of treatment, लेकिन palliative way of treatment. Main cause of disease diabetes, suppression of dynamic anxiety, fear, etc. According to homeopathic, diabetes disease, according to dynamic or treatment, holistic and individualization is the very important role of mother tincture. Is a not curative way of treatment, palliative way of treatment. Or जैसा artificial disease, access is of mother tincture use artificial disease produced in long time. It is
Yes, sir.
very, very thanks, Dr. Arora ji.
Thank you, sir. Thank you.
बहुत अच्छा,
Thank you, sir. That is why I divided into these stages. Maybe in the next, maybe somewhere down the line, we'll discuss those stages in detail, and then what is the outcome. Now, as sir said, the outcome, the complications. What are the expected outcomes in such patients at such stage? So that's another story. That's another thing to discuss.
Yes, tomorrow we will have a session from Dr. Sumana Kumari Panda, and Dr. will be presenting a paper on homeopathic approach to infertility due to blockage of fallopian tube, and that's program tomorrow. And today we had a wonderful session from Dr. SAURAV Arora here, and usually this is what I have noted is that the most troublesome patients are those who are the diabetes produced by the so-called iatrogenic diabetes. That is the most difficult thing to cure, and we may not be able to tackle that disease. What's your opinion on that, doctor? Then we can invite Dr. Hibbert to say what of thanks also.
Very nice, sir. We are very much happy to see you in always.
Doctor, please wait. Doctor will answer to my question, and then.
Okay.
Sir, see, iatrogenic diseases, again, if you think of the psychology and vitality, it was not the causation, it was the causative factor, the maintaining cause that triggered that miasm. let's come to the basic understanding of organ, that there is one causation that is dynamic, that we are born with, the genetic tendencies, that switch on, switch off button. Whatever triggered that button, whatever triggered that button has a role for the prescription for even iatrogenic diseases, for the patient having diabetes after taking certain medications or investigations, or even the operations, the surgeries for pancreatitis. Many of the patients, they undergo into diabetic problems if they're treated for the acute chronic pancreatitis and they're operated for that, right? So whatever it was a trigger, so we need to have that causation, that ailment, from take into consideration the miasmatic part, give a treatment, and then the story goes unified, that their sugar levels are not into sync, and if the pancreas is not making any insulin, that yes, we are, we have a challenge, that we should accept our limitation in that.
Okay, sir. Thank you very much.
Thank you, sir. Thank you.
Okay, so now we are expecting more from you, Doctor. I think that next time you will more do in researches of diabetic resistance. What are the conditions and
Yes.
causations of diabetic resistance? That is
Yes, sir.
very important. I think that
Yes, sir.
next time we will come with that.
Sure. I'll do that.
So we are very much thankful to you. All the classes you are doing in our Hindi session and as well as in English session, very much thankful to you.
Thank you,
You
sir.
are always welcome. We are very much happy to receive you in each and every condition. Thank you.
Thank you, sir. Thank you so much. Thank you to all, and have a good night.
With that, we come to the end of the day 1214, and it is over to Dr. Shaila to moderate the Malayalam session. Thank you all. Good night. Please unmute.
Okay, thank you, Dr. Dhanesh. Thank you all.